Welcome to the Heart of Prevention, helping clinicians stay up to date on preventive cardiology. This show features leading experts discussing real-world strategies to prevent heart disease, from lifestyle changes like diet and exercise to medical treatments, including new therapies. Whether you're a medical student, resident, or practicing clinician, this podcast challenges, informs, and enhances your approach to cardiovascular disease prevention. The Heart of Prevention, keeping hearts healthy one episode at a time. I'm Dr. Michael Shapiro, President of the American Society for Preventive Cardiology, and now here's your host, Dr. Keerthana Pakanati.
Dr. Lau, Dr. Dastmalchi, welcome to the Heart of Prevention.
Thank you. Thanks so much for having us.
Thanks so much. I'm excited to be here.
I'm really excited about today's topic, and we're going to be talking all about the heart and menopause. And this is part of our Women's Cardiovascular series that we're going to be sharing with all of our listeners. Before we get into today's topic, I'd love to tell you guys a little bit about our esteemed guest that I have with me today. Dr. Emily Lau is the co-director of the Mass General Brigham Women's Heart Health Program and assistant professor of medicine at Harvard Medical School. And Dr. Lily Dastmalchi is an Inova Shar Heart and Vascular Preventive Cardiology, Women's Cardiovascular Health, and Cardio-Obstetric Physician. She also leads the Menopause program at Inova Shar and is an assistant professor of clinical education at UVA Medical School and co-director of the nutrition curriculum. Thank you both so much for being here, and I'm really excited to dive right into our conversation. I always like to start off by asking, how did you end up where you end up, especially in prevention when a lot of the times you're navigating your course all on your own and figuring out kind of where you want to be in this realm of cardiology? What drew each of you to focus on menopause-related cardiovascular health, women's cardiovascular health, and what really keeps you passionate about this line of work? And we'll start with you, Dr. Lau.
Such a great question. I would say what drew me initially is how often I would encounter the same story. Women who were doing everything right, who were suddenly experiencing a very rapid shift in their weight, their blood pressure, cholesterol, sleep symptoms, and were being told that it was just aging or just menopause. But we know, of course, that the cardiovascular system is very much a part of the menopause transition. And what really keeps me passionate is that it's actionable. Menopause can be a moment when we really get women engaged, motivated. We can really work with them to interact with their healthcare system. And if we really use this time as a prevention window to think about risk assessment, lifestyle management, targeted therapies, I think we can really make a difference in changing the trajectory of cardiovascular disease for many decades.
I love that answer. I feel like everyone's story always starts with a patient or an encounter that really kind of shifts where they head with their career. Dr. Dastmalchi, what about you?
Yeah, I will say my interest in women's health has been pretty dynamic and has changed within the course of training, as much of our interests do from when we were in medical school to when we start our careers or within our careers. And I think what's interesting is that women have, and I'll call it a privilege, to experience all these different life stages where they're able to really experience changes in their health and take hold of their cardiovascular risk. So I at first was really fascinated by cardio-obstetrics, which I still am. Don't get me wrong, I still think it's incredibly fascinating. I love taking care of those patients. But how there's so many female-centric risk factors for cardiovascular disease that we don't learn about in medical school and we see clinically as we go on in our training. And then I learned more about menopause, the menopausal transition or perimenopause, however way we would just, determine to phrase it during this conversation. But I learned that even the changes during that time where you have lower levels of estrogen and progesterone, that the changes are so incredibly dynamic. And it's another life stage that women should feel empowered by and feel as though, okay, this is another moment of my life after pregnancy that I can change my health trajectory and change the way I want to live my life. So I just find it really interesting. And it also allows me a way of communicating with these women that makes them feel that I understand what they're going through. Granted, I have not entered menopause myself yet, but it's nice for them to feel like I learn and I understand and I want to be able to help them and lower their risk of cardiovascular disease and just increase their quality of life overall.
I love that you mentioned also that this is an opportunity for women to continue to take care and control of their health. As Dr. Lau mentioned, it would be dismissed initially, but this is an opportunity to not just say, oh, this is menopause or oh, this is just aging, but this is a call to action where you can actually make those changes and change the trajectory of, the rest of a woman's life.
Absolutely.
We've talked a little bit about how it's a transition point. Those are the words that you even used. But why is this such a critical window for prevention? And for clinicians that are like, isn't menopause something people see their OB-GYNs for? Like, this, what are we doing here? What's the cardiovascular reframe that you really think that we should share with our colleagues when it comes to menopause? And we'll start with you, Dr. Dastmalchi.
Yeah, that's a great question. I think it's really funny when a patient first sees me and doesn't know this is the work that I do and I'm interested in. When I start asking about their first menstrual period, their final menstrual period, obstetric history, any complications during their pregnancies. And women, it's so fascinating. Their memory is so in tune to certain life events, right? So when they first got their period, when they got pregnant, and any complications during those pregnancies. Then there's like a gap in whatever happened. And then now it's menopause and what symptoms they experienced and what they were doing and how old they were. And I think it's really nice to be able to have a deeper understanding of menopause where it's not just, it, you know, I guess what I'm trying to say is, let me rephrase this. I think a lot of patients, yes, I agree. They say, oh, I have to should see my OBGYN because they do women's health. Well, women's health is not just because of the differences in our sex organs. Women's health is a difference in our hormones and how those hormones play a role in our risk for cardiovascular disease. When our lipids rise, even before our final menstrual period, when we have changes in our sleep patterns because of the risk of sleep apnea during menopause. So there are so many things that change during menopause that's not just based off the reduction in hormones and your sex organs and that kind of symptomatic feeling that you may have, but it's also related to your cardiovascular disease and your risk factors that make it so fun to be in this field and be able to really do a thorough analysis and a full body evaluation as to how we can better prevent heart disease later on.
I love that comment about the full body approach to preventing heart disease. I think that is totally spot on with kind of what we're hoping to do in that preventive space. Dr. Lau?
So I really think of menopause as an accelerator rather than a single event in a woman's life. It's a period of time when baseline cardiovascular risk trajectory can really steepen. And this is especially true if a woman has had a history of pregnancy complications, metabolic syndrome, or other risk factors, to Dr. Dastmalchi's point. For me, the concept of the cardiovascular reframe is that we should really treat this time as a structured prevention visit. We should be reassessing ASCVD risk, blood pressure, lipids, glucose, weight trajectory, lifestyle, also including symptoms like sleep and hot flashes that we now know intersect strongly with cardiometabolic health. So in other words, I think we should really think of menopause not necessarily as a detour from cardiovascular care, as strictly a GYN issue, but actually a time for us to really ramp up cardiovascular prevention.
Yeah, absolutely. And you touched upon it right into our next question. For people that are listening that maybe don't really know how, lipid profiles or blood pressure, insulin resistant, visceral adiposity, vascular function, that maybe didn't get a chance to attend Dr. Dastmalchi's talk during ASPC, where I first got introduced to this topic. What can you tell us a little bit about what patterns clinicians should really be on the lookout for during this period or when they come in for that initial prevention appointment during their peri or postmenopausal timeframe? And Dr. Lau, we'll start with you.
Yeah, we actually know quite a bit about adverse changes in cardiometabolic health that occur across the menopause transition. The most robust data is for lipids. We know across the menopause transition that we see that women are much more likely to develop a more atherogenic profile. So LDL cholesterol, ApoB, they often rise. And then even HDL cholesterol often becomes less cardioprotective during this important life transition. And what we've seen is that these changes in lipid and lipoprotein profiles really seem to be beyond what we would expect to see for just age-related changes alone. So that really invokes the concept of, ovarian aging and reproductive aging as an important accelerator in lipid profiles. Beyond lipids, we also see a shift toward visceral adiposity. So a lot of women will come to me and say, oh, I've gained so much weight since menopause. And what's interesting is that the data show us that menopause is actually largely weight neutral, but there's a huge shift in the body composition. So we see a decline in lean mass, and an increase in fat mass, specifically visceral adipose tissue. And we know, of course, that visceral adiposity is a significant risk factor for later life cardiovascular disease. The data on blood pressure is a little bit more conflicting. There's a really interesting study that was done out of the SWAN study, which is a prospective study of the menopause transition, that suggested that perhaps women actually have different types of trajectories of blood pressure through the menopause transition, and that there's some heterogeneity in how blood pressure, changes across this important life event or life transition. So I think more data is needed in that space. And then finally, we see a lot of data demonstrating increased insulin resistance and worse vascular function.
No, absolutely. I do think it's a good point that you raised that patients will come in and that sometimes their first presenting symptom is their visceral adiposity. They're like, I feel like I've gained all my weight in my midsection. I don't know what to do. I'm just being told to work out more. I'm just being told to do this and don't really understand why that's happening. And so definitely a point for education. And I know I learned a lot from that answer. Dr. Dastmalchi?
Well, Dr. Lau did an amazing job explaining that. So I don't have too much more to add. But one of the things I would like to say too is that insulin resistance is very interesting. So we don't have clear evidence to suggest that diabetes risk or the development of diabetes increases during menopause. However, women who have family history or have risk factors such as gestational diabetes do develop diabetes. Additionally, what's interesting is that the increase in visceral adiposity that we see is pro-inflammatory. That is related to insulin resistance. So that can also increase the risk of diabetes. So again, managing those metabolic outcomes or the risk factors for insulin resistance is also incredibly important with weight reduction and a healthy diet with exercise. Additionally, one of the things I learned recently from a study from the SWAN study as well, it's a great cohort, it was the rise in sleep apnea. So women actually are found to have changes in their airway where it causes a higher incidence of sleep apnea, where now I actually recommend sleep studies in majority of my menopausal women who are found to have some element of hypertension or telling me they're having restless sleep, they're waking up in the middle of the night, because we know sleep apnea, again, a risk factor for cardiovascular disease and also can impact someone's quality of life during the daytime. And we know sleep is so important as is one of our life's essential aids for preventing the risk of cardiovascular disease. Lastly, I do want to add as well is that part of that cardiometabolic profile that changes is also the psychological health for women. I mean, I think that plays a huge role because women feel their bodies changing, their life is stressful, their mood is changing. If they have risk factors for anxiety or depression, they have higher incidence of major depressive episodes and anxiety episodes. So I think, like, again, looking at the full spectrum and having access to people who are specialized in this life stage and to refer your patients and to screen these women for this, because it all relates to our cardiovascular health, is incredibly important.
Yeah, absolutely. I think your point about saying that you have to look at this, holistically, and there's a lot of different things that play into each other, and making sure that we understand as we're learning more about this for everyone that's listening out there. I know for me, thinking about asking our patients these things, and the sleep apnea point is definitely something interesting. I'm like tucking that away for my clinic for later
Yeah.
this week. So I know we talked a little bit about some of kind of the lipid profile, blood work, life changes, things to look out for. Let's take a step back and talk a little bit about the other things leading up to menopause and how that really factors into our long-term cardiovascular risk and also things to look out for during the menopausal visit. So adverse pregnancy outcomes, early menopause, premature ovarian insufficiency. What do we know about how that relates to overall cardiovascular risk? And we'll start with Dr. Dastmalchi.
Yeah, great question. So I think it's important to know the time frames in which those occur when you see your patients. So menopause before the age of 40 is considered premature menopause. Menopause before the age of 45 is considered early menopause. And menopause after 45 is normal age range. Um, Premature ovarian insufficiency is also something that occurs before the age of 40. And that's also related to early menopause because your ovaries are no longer producing the hormones. Now, when related to cardiovascular risk, we typically say women are at higher risk for cardiovascular disease when they experience menopause prematurely or early. Um, and that's typically because you're losing the cardioprotective effect of estrogen, natural estrogen from your body, at an earlier time frame. So that is why we typically have found that women who experience menopause earlier, before the age of 45, have higher rates of cardiovascular disease, which is why it's a risk enhancer when you're evaluating women for their ASCVD or PREVENT score.
No, that makes a lot of sense. Thank you for those definitions. I think we have to make sure that we get those clear in our head, especially when chatting with patients. Dr. Lau?
Yeah, I agree with this concept of framing these reproductive risk factors as risk enhancers. That's really how I think about adverse pregnancy outcomes, early menopause, et cetera. And these risk enhancers, they don't show up in our standard risk calculators like the pooled cohort equations or PREVENT. And so if you're only looking at somebody's like LDL or blood pressure or their estimated ASCVD risk from these standard calculators, you may actually underestimate their lifetime risk. So I think it's really important for us to ask reproductive histories, to capture them in our documentation so that we can be really thoughtful and intentional in the way that we're managing cardiovascular risk in our women patients.
Absolutely. On that same token, one of the things that patients come in and ask, and I'm sure both of you have had this conversation numerous times, both in the clinic and also combating misinformation on social media. But if a patient really asks you, so what about hormone therapy? Is that safe for my heart? It's an oversimplification of a really long discussion that could probably be its own episode. But how do you really approach this conversation right from the beginning when they ask that question? And we'll start with Dr. Lau.
Yes, the $1 million question, the question, I think the central question of women's cardiovascular health. And I really start by validating the question because it's a very reasonable question. And just as you pointed out, patients have heard very mixed messages over the years. And then I try to separate symptom treatment from disease prevention. So menopausal hormone therapy is really treatment that should be used for treatment of bothersome vasomotor symptoms, quality of life, menopause-related symptoms, and not as a cardiovascular prevention strategy. And that's a really important distinction. And I really highlight this. I sort of, I say it and I repeat it several times because there's been a lot of misinformation about the use of menopausal hormone therapy as a cardiovascular preventive strategy. And as of today, the evidence do not support using hormone therapy for prevention of cardiovascular disease. But for patients who do have symptoms, I then risk stratified them. I look at things like their age, time since menopause, their cardiometabolic risk factors like blood pressure, lipids, diabetes, etc., and then any history of thrombosis and any known CVD. And so, in general, for patients who are appropriately selected and those who are younger and closer to menopause, hormone therapy is absolutely reasonable for symptom relief. Now, if somebody has had an established ASCVD event or they're at very high thrombotic risk, this is where we usually try to avoid systemic therapy if at all possible and pivot to some of our non-hormonal options. And then finally, I really discuss the route and formulation of hormone therapy for patients. For most of the patients that we'll be seeing in the cardiometabolic and cardiovascular prevention clinics, transdermal estrogen will be preferred over oral therapy. And this is because transdermal therapy avoids first pass hepatic metabolism that promotes clotting factors, inflammatory markers, et cetera, things that we know elevate cardiovascular disease risk. And then finally, we really do aim for the lowest effective dose. But ultimately, this is a really individualized decision, and there should be a lot of shared decision making with the patient, trying to understand what their goals are, what their risk profile is, and then, of course, periodic reassessment.
Yeah, thank you so much. Definitely not a one answer for everybody type of situation, very individualized. Dr. Dastmalchi, do you have anything to add?
Yeah, absolutely. So I agree. I think first answering what the patient's question is really important. So are they here to see me because they want to protect their heart and they think hormone therapy is the way to do that? Or are they having symptoms or they're referred by their primary care OBGYN and wants to make sure that, oh, if they have a history of cardiovascular disease in their family or within themselves or they have risk factors, is this person safe to start hormone therapy? I think, first things first, the FDA indications for hormone therapy are treatment of vasomotor symptoms and prevention of osteoporosis. That's the current FDA recommendations. Yes, things have changed with the black box warning, and that's a whole other podcast episode on its own, and we can discuss that later. But things have changed with the black box warning, but they do still enforce that to reduce the risk of cardiovascular disease is by looking at that critical window or by that Dr. Lau mentioned, where you look at their age and their onset of menopause. So if someone has had menopause less than 10 years, they could start hormone therapy safely, or if they're less than the age of 60. Now, speaking with some OBGYNs who do prescribe hormone therapy, that critical window is again pretty malleable. There's an if and situation. But again, I don't prescribe hormone therapy, so I just kind of go by the recommendations and the guidelines and the position statement from the Menopause Society. Now, when looking at women who could be who are indicated to start hormone therapy, again, like Dr. Lau, do risk stratification, whether you do a prevent score, a pool cohort equation. I sometimes use a calcium score as well. I do an LPA, lipids, blood pressure. Specifically, I also look at for history of autoimmune disease, history of SCAD. Those are things to really take into account. Again, history of stroke, really important to take into account before starting hormone therapy, because there are some contraindications. And there's a low risk where you can just kind of go ahead and start the medication. There's an intermediate risk, which if someone has obesity, cardiometabolic risk factors, you want to start transdermal typically. And then also the high risk people, you do not want to start hormone therapy, or you would consider contraindication for that. One thing to notice too, I think for clinicians is really important, is that if you have a patient who comes to see you and you notice their triglycerides are high or they have element of like hypertension, look to see if they're on hormone therapy and if it's oral, because oral estrogen can cause hypertriglyceridemia and sometimes can briefly elevate the blood pressure as well. I'm typically more of a fan of the transdermal route just because you avoid the dyslipidemia. But again, if someone's on it and you know, say, they have high triglycerides, instead of starting a medication or going down this whole rabbit hole, just look at their meds and see whether they're on oral estrogen, because sometimes that's the case. And you can switch them to transdermal with their OBGYN managing that.
Amazing. Yeah, lots of great tidbits here. Definitely not a one answer type
Yeah.
of question. And I think, for anybody that, wants to learn more, there's lots of resources out there and definitely focusing on the resources, both the Menopause Society you mentioned and our cardiovascular guidelines, OB-GYN guidelines, and kind of making sure that it's a very individualized approach for anybody that wants to talk to their clinicians about being on hormone therapy. Okay, so we've talked a little bit about, what happens to the body and then on the line of medication routes. So, when you're talking to people about lifestyle interventions during menopause, where do you start with that? And at what point are you talking about pharmacologic prevention? And how does everything kind of mix together in menopausal women? Big question, also with lots of answers, but I'll start with Dr. Desmalchi.
Yeah, that is a very big question, but I will try to minimize my response because I can be kind of chatty. So I think the first thing, it's lifestyle that brought me into cardiology and prevention, and I love nutrition. So I first talked to them about nutrition. And as we age, our protein requirement does change. However, I know protein is very trendy right now on social media. People are trying, we have the new food pyramid. That's a whole other podcast episode talking about doubling your protein intake. So all these things are happening, and protein is important as we age. We know that it's good for muscle rebuilding, for our tissues, everything of that nature. And I do recommend women to increase the amount of protein they take in. However, I still encourage a plant-forward Mediterranean diet that is low in saturated fat, just as the AHA and ACC recommend less than 5 to 6% of your daily intake. And one with lean proteins, if meat is within their diet, and avoiding red meat and processed meat or as much processed food as they possibly can, especially ultra processed food, I should say. Um, so that's kind of the first step. So I do a 24-hour dietary recall with my patients just to see exactly what they're eating in 24 hours. I ask if their diet changes when they're home or at work. When they snack, do they go to the fridge or the pantry, just to or the freezer, and just try to understand exactly what is their day like, what is their intake like. Based off that, then I ask them about exercise. What do they do for exercise? How much do they walk? Can they walk up 2 flights of stairs? Those kinds of things. And then when they are telling me, oh, I eat tons of protein, but I'm sitting all day, well, that's just excess calories at that point. You're not getting the benefit of the muscle rebuilding. You're not preventing the lean muscle loss that you're getting during the menopause transition. So I do recommend weight training for women safely. If it's within their financial budget to do it with like a trainer or a course at a gym, I feel like doing things alone like that, people can kind of become a little bit overzealous and carry a heavy weight and injure themselves. And I'm trying to prevent injury. Additionally, heavy weights is important for their bone health as well, and it makes them stronger and can increase their quality of life. So I think that's incredibly important. The other thing, oh, you mentioned pharmacological. So yeah, if that becomes another question. So when I do a calcium score, an LPA, and a lipid panel, that helps me understand where that person is in regards to their level of coronary disease or subclinical atherosclerosis that we may evaluate. And at that point, I do mention to them that maybe lipid-lowering therapy could be an option depending on what their LPA, their calcium score, and their lipid panels show. That's something I do want to optimize before they start hormone therapy, especially if they're going to start a oral hormone therapy, because again, it's not my favorite type, but it's one that can cause dyslipidemia. I think what's really important before starting hormone therapy is optimizing all the cardiometabolic risk factors, making sure that their blood pressure is well controlled, whether it's with medications or lifestyle change, and definitely both if needed. Their lipids are controlled, insulin resistance is evaluated, and typically if you see someone that has elements of insulin resistance, weight loss is kind of the first step in that regards. And then sometimes I do consider GLP because some retrospective studies I've looked at have shown that there have been some benefit in weight loss when women are on hormone therapy and GLP therapy as well. So those are things I look at. And again, the lifestyle changes while on GLP therapy is incredibly important. And that's a whole other conversation.
I love that you also mentioned that sometimes patients will make one change, like they'll eat a lot of protein, but not do the other changes, and really
Yes.
focusing on making sure that they're doing a little bit of everything. Because
Yeah.
I do think that sometimes, based on what we're seeing in the news or recommendations or social media, they'll kind of latch on to one thing that's trendy and they'll focus on that, kind of not necessarily meaning to negate the other stuff, but really bringing it back to you have to do a little bit of everything, I think is so important. And also kind of talking to patients before they initiate hormone therapy or once they've tried other things and kind of giving them different options, and every step, again, as this whole conversation has been, it's very individualized and it takes time to talk about everything with your patients. And I love the 24-hour food recall. I think that's just amazing. Dr. Lau?
Well, I don't think I can really add much more to that very comprehensive response, but I think your point that I really think of lifestyle interventions and pharmacologic prevention as something that we can do together. One doesn't negate the other. And also, needing to go on pharmacologic therapy is not a failure of lifestyle interventions, right? I think a lot of our patients come and sort of say, oh gosh, like I've been trying, I've been doing all these things right. And I really want to encourage them to recognize that pharmacologic therapy are just tools, just like lifestyle interventions, and they should really be used in tandem.
I love that comment because I definitely think women are hard on themselves to begin with. And especially, we mentioned earlier that they'll notice their bodies changing and they're like, I'm trying, but whatever was working before may not work as well anymore. And so thinking of it as a tool rather than as a fix or something that because they weren't able to do it on their own.
Yeah.
Pivoting a little bit, where we kind of talked about, how you all ended up in this field, but What gaps in training do you really feel like we need to address, or where do you see more menopausal education being, whether that's at the med school level, residency, fellowship, everywhere? Dr. Lau, we'll start with you.
In a word, everywhere. We really do not get any menopause related training from the beginning. And most clinicians are really not taught any sort of practical framework for counseling on menopause and especially on menopause related cardiovascular risk. As cardiologists, we don't get any menopause training. So I think we have a lot of work to do here. And I think this is obviously a challenging space. The messaging has historically been very confusing, which really highlights the importance of having more robust menopause related training from the beginning, at all levels of our training, and even for professionals who are practicing professionals. So I would say that there are a lot of low hanging fruit here, and we can do a lot better in terms of training our providers.
Dr. Dastmalchi?
Yeah, that's a great answer. And I completely agree. I think it should be everywhere. It should start in medical school. We should really understand what is happening in a woman's body when they go through pregnancy thoroughly. Like, what are the risk factors that happen? What about menopause? What's going on? The menopause transitional period can last up to 10 years. That's a full decade. That's a huge part of someone's life. And I think it's really important to appreciate the complexity that women go through rather than just being like, oh, brush it off, it's menopause. So I think it's some of that nature of just kind of brushing it off and be like, oh, it's menopause, it's anxiety. It's because the woman's body is so complicated, but in a really intriguing way that we don't really have the access, or we get intimidated to learn what is happening and how we can apply it to our clinical practice. As cardiologists, I think we know that women get coronary disease after the age of 60, 10 years after men, but understanding why that is so important, and something that's so dynamic as cardiology and always becoming more advanced. Understanding why these changes are occurring, why coronary disease is happening at this stage in a woman's life is so important. Does everyone have to do as much of a thorough intake as Dr. Lau went out? No, probably not. But I think asking the basic questions of any complications during pregnancies, if you've been pregnant, um, had final menstrual period. That's all you have to ask. And then, if you want to go into a little bit more detail, are you having any hot flashes or night sweats? And that's like within the age of maybe someone between the age of 40 and 60, you can ask those questions. But overall, I think it's something that's completely underappreciated in the medical literature and in our research. And we definitely need more access, more education throughout, starting from medical school and throughout clinical training, starting with internal medicine, the subspecialties, and definitely in cardiology.
Awesome. So we're playing a catch-up game is what I'm hearing.
Yes.
Um, so I wanted to talk briefly about, as if we haven't already said this enough, menopause experiences vary widely across all of our patient population. But how do you find that race, ethnicity, culture, and even social determinants of health, which is a big part of any part of a person's life, how does that really shape the way you approach person's cardiovascular risk and care during the menopause period? I feel like all of these questions could be their own episode, but Dr. Tasmalchi, we'll start with you.
Yeah, no, agreed. It could be a podcast episode on its own, but I think it's really interesting how culturally menopause is shaped, or how culture shaped the menopause transitional period and the experience people have with menopause. So for example, I talk about this with my mom a lot about menopause and how I'm like, well, it's great that now social media has been a great way, even though there are some negatives of social media, it's been a great way for empowerment for women. Women are now asking questions that they never asked before about hormone therapy, or even like, what does menopause mean to my overall health, or asking about dietary changes and exercise changes. And I think it's great. Um, Talking to my mom, coming from a Persian background, she just says, we don't talk about it. She was like, I don't even know what symptoms I had. You just like go through it and you call it a day. You guys make it such a fuss. And I'm like, well, hold on. I was like, this is a pivotal time in a woman's life, like this is something that we need to talk about. So when I meet patients of different cultures, I do ask them these questions, and the responses, depending on the culture, is incredibly variable. Sometimes they're like, it was fine. And or they're like, I still have hot flashes, but I just deal. And it's like, well, maybe we could do something. You don't have to experience them if you don't want to. So I think culturally, I think it's incredibly important. Sorry, I think it's incredibly important for clinicians to be culturally aware that patients experience things so differently. And unfortunately, we also have data that shows that people who are of minority in the US don't get screened for menopausal symptoms. They aren't offered medications for menopause. It's similar to like cardiovascular risk. They're at higher cardiovascular risk. Also, as a result, because vasomotor symptoms on their own have a higher rate of can cause cardiovascular disease. So I think it's a very complex question, but overall, we just need to ask our patients the questions and see what they're going through and just be more culturally sensitive.
I feel like your description of your mom sounds like my immigrant mother as well. But I do think it's because traditionally it's just been something that's been brushed over, and maybe there are patients who feel like they've not been listened to when they describe those symptoms, so they're just told to deal with it. And so I love the fact that you're like, we just have to ask. We just have to ask and start asking those questions and be culturally competent for whatever response we're gonna get. And then Dr. Lau?
Yeah, absolutely. I think it really affects trust. If women feel dismissed, if we say, well, it's just menopause and this is a really real experience for them. And of course, we know that some women go through menopause with very few symptoms and others have debilitating symptoms. But if women feel dismissed, they're going to disengage, right? So I think we really need to help name the physiology, validate symptoms, offer real concrete steps. And we really also need to be thinking about building systems that can make menopause care more accessible. So thinking about affordable medication options, accessible lifestyle programs, and really importantly, coordinated specialty care so that patients themselves don't have to be advocating endlessly for themselves, that it's actually part of the healthcare system.
What a great segue into my next question about collaboration between cardiology, primary care, and gynecology, obstetrics. And, in a perfect world, in your dream world for menopausal patients, what would that collaboration really look like? Especially, you just mentioned patients having to constantly advocate for themselves. So I'd love to hear what your ideal collaboration looks like. And we'll start with Dr. Lau.
No, ideally, I think it would be a shared playbook. You can imagine a scenario where primary care can screen patients, initiate cardiometabolic prevention. Gynecology can also screen for cardiovascular risk factors and, of course, refer when needed. And then us as cardiologists can help to risk stratify and manage more complex prevention and really help to support more nuanced decisions for patients who are at higher risk. And importantly, the patient shouldn't have to be the one that's carrying the message between all of their specialists, right? We need to be doing a better job of documenting menopause stage, symptom burden, reproductive history, risk enhancers. All of these things are not well documented in our health records. And these are the things that should follow the patient. And that way, it's not, the onus is not on the patient in ensuring that they're getting the appropriate care.
That's a great point. I was thinking about when you mentioned that not a lot is documented really well. Back to when Dr. Dastmalchi at the beginning was like, women are really in tune if you ask that question of when was their first period or when any issues during pregnancy. But I'm trying to think about how often I see those answers in the chart, and it's not very often at all. Um, Dr. Dastmalchi, what about you?
Yeah, that's a great question. I think there are multiple players in the care of a menopausal woman. I think it goes beyond just primary care and OBGYN and cardiology. I think primary care and OBGYN are major players because they're typically the first ones who are seeing this patient or these patients, I should say. And then they appropriately refer to cardiology, as Dr. Lau mentioned, for more complex prevention and risk stratification, especially if they're on hormone therapy or they have family history that needs to be further evaluated. I think what really makes a menopausal program really strong is, again, constant communication, organization within the major players, including neurology, sleep medicine, pelvic PT, oncology. So these are it's a multi-dynamic platform, and I think all of these players need to work together. And I'm sure I'm missing another endocrine. Sorry, there's so many subspecialties and so many
No, yeah.
behavioral health. They can keep going, but I think it's so important to have this multidimensional program so that women, when you see them, know that there's someone who's a specialist that'll be able to further evaluate and appreciate what they're going through during this incredibly important life stage.
I think it's an important point that you just made that there's so many people involved because there's so much going on. And we can't just breeze over this. I mean, we could list all of the specialties. And I think I love the fact that you both mentioned that it really is a team sport and we should be communicating effectively to really provide the best for our patients. So we've kind of talked about a lot of things, but I thought we'd do a little rapid fire to wrap up the episode. I know you both are really polite and probably going to wait for each other anyway, so I'm not going to say shout out and answer, but we can take turns answering the questions. Um, the first one that I have is, what is the biggest aha moment you've had about menopause and the heart? Anyone can take it.
I guess, what I've realized is, as women are living longer, I think I stumbled upon the statistic, which is that women can spend up to 40% of their lives in menopause. And that's a bit, that's a large chunk of one's lifespan, right? So this is a really critical, important life transition. And I think we really underestimate its impact on women's overall cardiovascular health.
That is a long time. Yeah.
I think for me, my aha moment was in fellowship when one of my mentors mentioned to me that HDL cholesterol is sometimes elevated or just dysfunctional during the menopause transition. And he showed me a paper and I read it and I was like, this life stage is fascinating. Why is this happening? So from then on, of course, I learned more about the literature and the science behind it. But when I see women come see me who have dyslipidemia and they're like, well, my LDL and HDL ratio is really good. I was like, yes, but let's learn more about HDL together. And I explained to them that it's dysfunctional and it's not as good as being cardioprotective as it used to be during this transitional period. And I think that moment in fellowship is really what kind of like drew me into this life stage and made me realize the intricacies of women's health in general.
And what is one thing you guys wish that every patient knew before entering perimenopause or the menopause stage that maybe they didn't get told before they come to see you in clinic?
I think one of the things I think they wish they were told or that social media would also kind of advocate a little bit was something we mentioned actually earlier is that pharmacotherapy isn't bad. Like I said, I'm someone who is very much a proponent of lifestyle. Lifestyle is so important, but part of that lifestyle is taking sometimes medication. Like I mentioned before with cholesterol, the dyslipidemia. Sometimes you can't bring down your LDL cholesterol, just diet and exercise during menopause. The LDL cholesterol raises exponentially 5 years before the final menstrual period. So sometimes we need a statin, or I just frame as lipid lowering therapy. So no one, jumps to a conclusion. But I think pharmacotherapy isn't a bad thing. Hormone therapy is also pharmacotherapy. So if you want to try that, why not try something else that'll help protect your heart as well? So I think that's something I wish my patients would be more educated on, that it's not just hormone therapy and that's it, but it's also like there's other players that play a role in helping protect your heart and making you feel better.
Absolutely.
I would say that I wish every patient before they entered menopause, before they became perimenopausal, knew that it's a very normal transition, but you do not have to suffer through it, to the points of our discussion earlier. And it's also a very important and a very good time to be checking in on your heart health.
And the last question is, what do you hope will be different in menopause care 10 years from now? What's something you'd like to see change?
I'd love to see menopause care integrated into cardiovascular care, that it doesn't feel like it's siloed. And of course, we always want our care to be standardized, evidence-based, accessible, but really a part of cardiovascular care.
I'm hopeful that we'll have more research by then and a better understanding. So everyone's kind of on the same page about hormone therapy and there isn't all this back and forth between different groups. And again, I agree with Dr. Lau, having it integrated in our cardiovascular practice and not making it seem intimidating would be wonderful. So women get equal care from their physicians and their clinicians.
Well, this has been an incredible discussion. I feel like I've learned so much and we've barely scraped the surface. And I can't wait to talk more about menopause and the cardiovascular health of our patients. And thank you both so much for taking the time to chat with me. And I'm sure we'll have lots of people wanting to learn more about menopause and become, menopause cardiovascular health providers.
Thank you so much. And thank you for really spotlighting this important issue.
Absolutely. Thank you. You did a wonderful job, and it was great to learn from both of you as well.
Likewise.
Thank you so much for listening. To learn more about the ASPC, please visit our website at aspconline.org.